Hello everyone, welcome back to the series of lectures in hepatology. Today we'll be discussing another very important topic which has undergone a lot of changes in the recent past. This is your Metabolic Dysfunction-Associated Steatotic liver disease, okay, which is your MASLD. So let's begin. So the first and the most important change that has happened is your change in the terminologies. So what is MASLD? So MASLD is Metabolic Dysfunction Associated Steatotic liver disease. Okay, so we have to understand very clearly what does each word mean. Okay, so metabolic dysfunction basically means that any group of disorders which are characterized as metabolic disorders, which includes diabetes, hypertension, dyslipidemia, hypothyroidism. Okay, so the liver disease which is associated with any of these metabolic disorders. Okay, so metabolic dysfunction is any of these disorders. So metabolic dysfunction associated liver disease. And what is this word steatotic mean? So this word steatosis or steatotic means accumulation of fat. Accumulation of fat. So in essential, this word explains what is happening in this disorder. So as a result of this chronic metabolic dysfunction, there can be accumulation of fat in the liver and this results in your MASLD. So now you can pretty much guess what were the old terminologies used. This was also called as NAFLD, right, or fatty liver disease. Okay, so what is NAFLD? NAFLD basically refers to non-alcoholic fatty liver disease. So in the olden days, what it was being used as, alcohol was one of the most common causes or the most identified cause for liver disease. So those patients who had alcoholic liver disease were classified as alcoholic liver disease. Those patients who did not consume alcohol and develop liver disease were classified as non-alcoholic liver disease. Okay, but this terminology has been changed to understand the basic pathophysiology behind this is because of metabolic dysfunction. Okay, so that's why the term NAFLD or NASH, which is non-alcoholic steatohepatitis, is not used anymore and it is called as MASLD. Alright. So what is MASH? MASH is the same thing, which is metabolic dysfunction associated steatohepatitis. Steatohepatitis means accumulation of fat along with the inflammatory changes which happen in the liver. So MASLD becomes MASH when it progresses. Now what is MET-ALD? What is MET-ALD? It is metabolic dysfunction plus alcoholic liver disease, right? So it doesn't mean that a person who has metabolic dysfunction will not have alcohol, right? So if there is alcoholic liver disease along with metabolic dysfunction, it is called your MET-ALD. And what is the dose at which a patient develops alcoholic liver disease? When the dose is more than 30 to 60 gram per day in males. When it is more than 30 to 60 gram per day in males, you can have an alcoholic liver disease. Okay, so I hope these terminologies are clear. Fine. Now let us understand the epidemiology. Okay, so the most common cause of CLD worldwide, is actually your MASLD. Okay, and it also has been found out that certain races are immune to it, certain races are more prone to it. For example, the Americans are more prone to MASLD, whereas the black race is less prone. Okay, now you can easily identify what are the risk factors. We have just now discussed any disorder which affects the metabolism, right? So diabetes, hypertension, okay, dyslipidemia, hypothyroidism and obstructive sleep apnea. All of these are risk factors for the development of your metabolic dysfunction-associated liver disease. Now let us understand, before going on to MASLD, what are the causes for fatty liver disease. Right, so every time that you have a fatty liver disease, it need not mean that it is only MASLD. Before you diagnose a patient as MASLD, you have to look at all of the causes for which there is fatty liver. Okay, so what is the basic thing in fatty liver? So there is accumulation of fat. There is accumulation of fat globules in the liver. So the most important cause is your alcoholic liver disease. So every patient of liver disease, before you diagnose them as MASLD, always take a good alcohol consumption history. Apart from this, viral hepatitis, especially hepatitis C, can cause fatty liver. Inborn errors of metabolism, this includes your galactosemia, glycogen storage disorders, hereditary fructoseuria, hemochromatosis, Wilson's disease. All of these can cause fatty liver. Now you would be thinking that metabolic dysfunction-associated fatty liver disease is more common only in obese individuals because they have diabetes, hypertension, dyslipidemia, hypothyroidism, OSA and obesity. But there can be certain individuals where there is a problem with the lipid metabolism, and there can be abnormal accumulation of lipids even in lean individuals, which is called as lipodystrophy. Okay, so even lean individuals can have a fatty liver. Other causes of fatty liver includes inflammatory bowel disease, and when they undergo surgeries. Now let us say that they have undergone surgeries such as intestinal resection. So when they have intestinal resection, there is fat malabsorption, right? Because the fats get absorbed from the intestines, there can be fat malabsorption. Over the course of time, there is fat malabsorption, accumulation of fat, and can cause fatty liver. Then there can be other causes like acute fatty liver of pregnancy, and always rule out drugs, cytotoxic agents, cancer chemotherapy, heavy metals, amiodarone, glucocorticoids. What is HART? HART is highly active antiretroviral therapy, which is your drugs used in HIV. Okay, then your contraceptives such as tamoxifen. So there is a huge list of causes for fatty liver. So before you directly go ahead and diagnose a patient as MASLD, always take a good history, do a good clinical examination, look for other causes of fatty liver, or keep it in mind and keep it as differential diagnosis before you diagnose a patient as MASLD. Okay, fine. Now let us understand the pathogenesis. How does this fatty liver happen? So the first stage, now this is your normal liver. The first stage is that whenever there is a metabolic dysfunction, metabolic syndrome, obesity, hypertension, dyslipidemia, diabetes, then there is accumulation of fat. So there is accumulation of fat. So this is what we call as steatosis. There is steatosis. This is what we call as your steatosis stage. Now as it progresses, what happens is that there is a continued inflammation. So basically this fat accumulates and it causes an inflammatory milieu. It causes an inflammatory environment. Now there is continued inflammation, and this results in what we call as steatohepatitis. So initially fat accumulation, later on there is inflammation. So steato means fat, hepatitis means inflammation of the liver. Over the course of time, what happens is that this inflammation is tried to control, but there is accumulation of fat, inflammation again. Then there will be degeneration, regenerative process, and there can finally be fibrosis and cirrhosis of the liver. Okay. So there are certain heritable causes or genetic disorders which can predispose you to more severe form of fatty liver disease. This includes disorders which are deficiencies in your lipid transporters such as TM6SF2 and MBOT and PNPLA3. So these are genes which are basically involved in effective lipid transport. If they are damaged, there will be accumulation of fat in the liver. So what is this showing? So this is basically showing you that there is an imbalance. There is an imbalance between your triglyceride synthesis and triglyceride removal. right? So the removal of triglyceride has decreased and the synthesis of triglyceride is more, right? So what happens? There is a lot of fat accumulation in the liver, and over the course of time there is lipotoxicity. These lipids which accumulate are in fact toxic, and when they get metabolized there is lot of generation of free radicals and they cause damage to the liver. So why is it that it is seen in obese individuals or in patients with metabolic syndrome? Because there will be insulin resistance. There will be insulin resistance. Now, insulin resistance means insulin is not able to act on the receptors. If the insulin is not able to act on the receptors, then this insulin is going to increase in the blood. Increased insulin is going to promote what? It is promoting lipogenesis. So there is more fat production and there is going to be more fat accumulation. Okay. So this is about your entire pathogenesis of your non-alcoholic fatty liver disease, which we do not use anymore, which is your MASLD. Alright, fine. Now let us go to the clinical features. How does a patient with MASLD present? So MASLD patients basically present with what? They present with fatigue, malaise, vague upper quadrant pain. Most of the time MASLD patients are usually identified on a screening ultrasound when they come for a regular health checkup. But apart from that, they can have your vague fatigue, malaise, vague upper quadrant pain mainly because of hepatomegaly. When you examine, you will have some hepatomegaly. So what are the laboratory features that you will find? The laboratory features that you will find with concerning to the liver function test, you can have hypoalbuminemia, sometimes because it's a chronic inflammatory condition. Then AST, ALT can be mildly elevated. But it is not always, but it can be mildly elevated because this is a hepatocellular type of problem. Okay. Then you can have dyslipidemia, total cholesterol, LDL, triglycerides, all of these will be high, HDL will be low. Then you look at the HbA1c and you look at the fasting blood glucose, you see for any evidence of diabetes. Uric acid levels can be high because it can be associated as a part of metabolic syndrome. Apart from that, you can have evidence of hypothyroidism where the free T4 is low and the TSH is elevated. Okay. So these are about the various laboratory features which you can find in association with NAFLD. So how do you diagnose? How do you diagnose this metabolic dysfunction-associated steatotic liver disease? So there are a group of non-invasive as well as invasive tests. So the non-invasive test will definitely be your laboratory features. Then in your ultrasound, you can find evidence of fat deposition. You can find evidence of fat deposition on your ultrasound. Okay, right? So you can find evidence of fat deposition on your ultrasound. Another non-invasive technique that we use is a fibroscan, which is also called as your transient elastography. Right? So what is the use of this elastography? It is a technique which is basically used as a non-invasive method to find out the resistance or the fibrosis of the liver. So using this fibroscan or elastography, you can find out at which stage of fibrosis the liver is in. Right? So these are your non-invasive tests. Invasive test includes the final diagnosis or definitive diagnosis is brought about by a liver biopsy. You do a liver biopsy and you find evidence for deposition of fat. Okay. So the staging, how do you stage? The staging is brought about by your transient elastography. Okay. So this is mainly measuring your liver stiffness or the stage of fibrosis. So if the liver stiffness is between 8 to 12 kilopascals, if the liver stiffness is between 8 to 12 kilopascals, then this is intermediate stage of fibrosis. This is intermediate stage. So what happens is when you do an elastography, how will you obtain your report? The report will basically show the liver stiffness in terms of this kilopascals, right? And apart from that, you also have a color grading. So as a physician, when you look at the report, you will know at which color grading it is shown or what is the liver stiffness. So depending upon this liver stiffness, you will know what risk stage they are in. It is basically used for staging, right? So you will know at which stage of fibrosis they are in, right? Are they at a steatosis stage? Are they at a steatohepatitis stage? How much of fibrosis has already happened and how much is left? So this way you will know how you will be able to counsel the patient. Look, you're going towards cirrhosis, so you have to be careful. Or if you're already in cirrhosis, then you have to treat according to your CLD protocol, right? So that is the whole point of this. If your liver stiffness is between 8 to 12 kilopascals, it means you are in your intermediate stage and you have to do an MR elastography. MR is your magnetic resonance elastography. In your MR elastography, if the stage is between 2.5 to 3.6 kilopascals, then you are still not sure. Then you have to do a liver biopsy and see if there is evidence of cirrhosis. Okay? If your MR elastography is directly above 3.6 kilopascals, then that means that you are already in your stage 4 cirrhosis or stage 4 fibrosis. And if your liver stiffness on your transient elastography is also called as your fibroscan, or this is an ultrasound based report. If it is already more than 12 kilopascals, then you are already in stage 4 fibrosis. So stage 4 fibrosis means that there is already some cirrhosis which is setting in and you have to counsel the patient accordingly. If the liver stiffness is less than 8 kilopascals, that means that there is no fibrosis and you have to monitor them and you suggest some lifestyle medications, make sure that dyslipidemia comes down. Okay? So this is about how you diagnose your metabolic dysfunction-associated liver disease. So we have learnt about non-invasive and invasive tests. We have understood what is the fibroscan. If the fibroscan is intermediate, you do an MR elastography. On MR elastography, based on your reports, you decide whether you want to do a biopsy or not. If it is already more than 12, no need of liver biopsy, directly you are going into cirrhosis. So the ideal number which you would be looking for is your liver stiffness less than 8 kilopascals. Your liver stiffness less than 8 kilopascals. Now let us understand on biopsy what are the changes that you would find and how do you stage and grade this metabolic dysfunction-associated steatotic liver disease. Right? So we have learnt about the basic architecture of the liver. The basic structural functional unit is your lobule. So this is the diagram which is basically showing your liver lobule. So you have the central vein followed by the portal tract surrounding it. So between two portal tracts we have another functional unit which is devised for understanding the grading and staging of this MASLD, and this is what we call as the acinus. So this entire portion that you are seeing here between two portal tracts is what we call as the acinus. Okay, fine. So grade 1 basically means that there is steatosis. Okay, so grade 1 when you do a biopsy means that there is steatosis. So steatosis means there is accumulation of fat globules in the liver. However, the portal tracts are not inflamed and they can be only scattered intraacinar cells. So if you see here, there is only some cells which are basically scattered here, right? So within the acinus there are only some scattered cells. There is very minimal inflammation and there is only steatosis. There is no portal inflammation at all. Okay, there is no portal inflammation at all. In grade 2, steatosis is there. Apart from that, you will find ballooning of hepatocytes. The hepatocytes become ballooned like this, right? And then you can have portal inflammation. And there is fibrosis which is predominantly in zone 3. So this is your zone 3. So this will be your zone 1, this is your zone 2 in the acinus, and this will be your zone 3 more towards your central veins. Okay. Grade 3 is when you have pan-acinar steatosis. The steatosis initially will be only about 60%, 65% and so on in your grade 1. When the pan-acinar steatosis happens, this entire functional unit which is your acinus gets affected. There is complete steatosis, right? And there is complete ballooning of all your hepatocytes. You have portal inflammation and inflammation is extending beyond zone 3 as well. So this is how histologically you grade your metabolic dysfunction-associated liver disease. The staging is basically done by your fibroscan as we had just discussed now. So F1 stage is your zone 3 and perisinusoidal fibrosis. Zone 3 and perisinusoidal fibrosis. If in your stage F2 there is portal fibrosis as well, right? In your stage F3, so initially where is yours? So your fibrosis is somewhere here in your zone 3. Zone 3 means zone 3 of the acinus. Then the fibrosis basically goes in your portal system as well, right? So these are your portal tracts which are at every corner. So there is portal fibrosis also. Then there is a bridge. Okay, you are understanding there is a bridge. Bridge between what? So in the center of your lobule, you have your central vein, and at your 6 corners, you basically have the portal tract. So the inflammation is in the portal tract and the inflammation is in your zone 3, which is near your central vein. Now there is a bridge which is formed between your zone 3 and your portal tract. Can you see this bridges? This is what we call as bridging fibrosis. So there is bridging fibrosis in stage 3, and finally in stage 4 you will have cirrhosis. So stages F2, F3 and F4 is what we call as your advanced stage. Is called as your advanced fibrosis stage. Okay. So this is a little higher level topic, but just to complete your understanding on MASLD, we are learning about this, right? So stage 1 is where there is only your zone 3 and your perisinusoidal. Stage 2 involves the portal inflammation as well. Stage 3 there is a bridging fibrosis, and stage 4 there is cirrhosis. So this is wonderful because this is a non-invasive way of identifying what stage of disease you are at. Okay. Now let us understand the management of your MASLD. So the first and the most important is your diet and exercise. So you counsel the patient that, hey, you've got your metabolic dysfunction-associated steatotic liver disease. So you have to take care of your diet. You consume a low-fat diet, and sometimes even a Mediterranean diet is encouraged. Okay, that is predominantly involving fruits and nuts. So you increase your good fat, do not have fried food, right? So you consume a low-fat diet. Adequate aerobic exercise of at least 30 minutes per day, at least 5 days a week. Okay, so this also has to be taken care of. Then we look at drugs. So if you are doing all of that, but there is no improvement, then we look at drugs. In patient without diabetes, there have been no definitive FDA drugs which have been approved for the treatment of MASH yet. But without diabetes in patients, vitamin E has been tried, right? And with diabetes, till now we have used one drug, and that drugs is your group of drugs which is your thiazolidinediones. Okay, like your pioglitazone or saroglitazar. Okay. Apart from this, certain other drugs like metformin and SGLT2 inhibitors recently, like your dapagliflozin, have been tried for MASH, but they have not yet been definitely FDA approved only for this indication. Apart from that, your GLP-1 receptor agonists like your liraglutide or semaglutide. Okay, all of these have found to be beneficial in your MASLD. The only advantage is that all these drugs are used in patients with diabetes, with MASH, then you can use these drugs. The problem with pioglitazone is that this can cause a lot of edema, and this can precipitate heart failure, right? And if long-term use, there are certain safety concerns. So pios is not used in the long term. So the now newer drugs which are useful in MASH, but they are not FDA approved for that particular indication, is including your semaglutide and your SGLT2 inhibitors. Okay. The final treatment would be a liver transplant, right? So this brings us to the end of our discussion on MASLD. So we have learnt about the terminologies, clinical features, how do you diagnose, what is the utility of fibroscan, and the management. Thank you.